used to, right? But let's put this as close. Alrighty. Let's see. Oh, there it is. Definitely don't like that. Where'd it go? Off. One, two, three, 1, 4, 7. Six, 3, 6, 6, 7, 2, 7, 6, 5, 8. Oh, okay. Who is that? Okay.
Happening again. I was gonna say hi.
Just a couple things. I apologize in advance. I am having some GI issues through treating, so I tend to burp a lot. So hopefully I don't do that too much during here, but just so you know. The other thing is please be aware my wife has advanced Alzheimer's, So occasionally she may wander into the room. So if I pause just for a second, that's typically what's happened. I have to turn around and get her to head back out of the room. So anyhow, a little bit about me, because I know you guys probably don't know who I am. Basically, I'm an LVN, just where you're striding to get to, just so you know. I've been with American Career College since 2008. I launched a VN program at Ontario, so I'm basically the only surviving member of the actual launch team, basically. So I started with cohort 1 and sort of been with the program all the way through. Basically, I've had some experience. You know, I've worked when I was younger. I worked in emergency medicine. I used to run advanced life support. Worked in the fire department as a firefighter, EMT. Basically, worked for an oncology practice for 11 and a half years. Sort of I ended up getting cornered by my nurses, a BSM, MSN, and an LVN that I hired, and told me that I needed to get a license because I had too much knowledge. So then I went and I got my LVN because that's all I could do working full time with that. So I did the nighttime program, or what they call VNU at the Ontario campus, and so I was working 50 to 60 hours at the practice, and then I was spending about 20 hours for school. So, I sort of understand sometimes the fun that it is, especially if you're working and trying to go to school and do what needs to be done. So just so that you know a little bit about me, and of course, like I said, I started with American Career College in 2008, so I've been with them, I think it's like going on 16 years now. So that's pretty much me a little bit in a nutshell, just so you sort of know. Basically, I don't require you to have cameras on. I figure this is all voluntary. You're here because you're working at improving yourself, getting ready for your NCLEX or your exit exams, whichever it might be. Excuse me. So I just ask if you would just please put your name in the chat box for me. I would appreciate that, just so I have a record of you being here. And then also I let Mr. Montano know because he's going to ask me. And so if your name's in the chat box, that just makes it really easy for me to pick it up and send it to him with that. So tonight we're going to be going over, I'm sure he sent out the calendar, so we're going to be doing, basically acute conditions of children, basically with that. And then we'll sort of just progress through. I carry out my calendar so long, and then I switch it up the next time around. So if anybody's still hanging in, then basically I'm not just constantly repeating the same stuff over and over again. So without that there, we will see how we do. I'm not a technological genius, so sometimes I do have a problem. Hopefully no problems tonight. And oops, what I just do? Okay, I want to share the screen. Oh, there's my stuff. Okay, like I said, I don't require the cameras or anything like that. Once I go into shared screen, I really can't see you anyhow. Oh, what I just do? Give me a minute, I just did something wrong. Yeah, are you guys able to see my screen where it says child with acute condition? Boom. Okay. All right. So the other thing with this, when I'm doing this, if you got questions or something, don't hit the little hand raise button or type something in the chat box, because I can't see it when I'm in shared screen, and it's just me, so I will never know until I actually close things out that you actually put something in there. So basically, I don't have a problem if you got a question or something. Just shout it out. It's not going to bother me with it, and I'll do my best to answer it. If I don't know the answer, I definitely will let you know. Okay, just so you're aware of it, and don't be afraid to ask questions. That does not bother me at all, because that's how you're going to be able to learn and move forward. And let me get my other things. They changed stuff on me. So there we go. All right. So anyhow, basically here we got croup. So if you watch, basically it's also called acute epiglottitis. Yeah, glottitis. My tongue is really fun tonight. A couple of things you'll learn also with me as we do things. Terminology that I know well and I pronounce well, and other stuff not so much so. And my spelling is atrocious, so just so that you know. And that's why when I used to work in the practice and stuff, when I was documenting, I always had a medical dictionary and a word finder next to me so that when and stuff of that nature. So, I got my licensing like that. So, if you have that same problem, then hey, you know that you can do it as well. So anyhow, like I said, if you think about it real quick, you see croup, and you know that basically, this one here is acute epiglottitis. Basically, right there, we're concerned with what? If I have inflammation of the epiglottis, what's my concern? Anybody know?
Airway.
Yeah, that's going to be my big concern, airway, right? So basically, a lot of times there, even if you don't know all of it, but at least you have that tagged into, your thought process when you're taking your NCLEX and you get a question like that, at least now, depending on how the question goes, you got an idea of where you're going to go when you're looking at your options to see which option would be the best. So anyhow, like I said, it's bacterial, usually H. influenza, most common between 2 and 5 years old, basically who's predominantly affected with it. And of course, like it says, the onset progresses rapidly. You can see basically with the epiglottitis and the croup. So, there's two types in there. So with it, if you watch, and you can sort of see listed there, so you can sort of look at it and just go and see sort of the difference between the two. So, you got croup syndrome, which can incorporate one or both of these into the picture as well. And of course, if they had the acute epiglottitis, that's something that we'd be highly concerned with. And of course, like it says, the child's going to look very unwell, very sick with the epi. And of course, with croup, they look all right. And of course, basically with it, if you watch, the fever, they can have high versus moderate with it. And of course, stridor. And of course, if you think stridor, that's a high-pitched squeal that comes out of the throat. And if you remember, a lot of times stridor, that can indicate an airway obstruction when we hear that. So if we hear stridors, we get very concerned because that could indicate that the airway is being obstructed because that's air trying to move through a very small space, right? So, if you watch the epiglottis being inflamed, because, itis is inflammation, that's inflamed. So that's going to restrict air movement into the lungs as well as coming out of the lungs. Where with croup, it's mild to moderate. And of course, basically with coughing, with the epiglottitis, basically, with the cough, they have minimal or no coughing going, where with croup, it's a barking when they, basically sound, or it says a seal-like quality. So you can sort of differentiate between the two of them by listening to what they're actually doing, if they're coughing. And of course, basically, if you watch with speech, if you watch here, unable to speak. Now, if you're thinking about unable to speak and you keep in mind what the epiglottis is, this is inflamed, right? In order for us to speak, what do we have to have? You guys know? What makes it so we speak?
The larynx?
Well, yeah, you got to have that, but we got to have the vocal cords, right? And those sit in the glottis, which is just below the epiglottis, right? But in order to speak, if you think about it, right? Remember, you said airway was important. That's what you said when we were talking about this one with inflammation. If you think about it, in order for us to speak, we have to have air that comes up through the trachea to vibrate those vocal cords to make speech. So if somebody is unable to speak, do you think there's going to be, do you think that indicates there's a severe, right? If you think about it, it's sort of just like, if you remember somebody choking, you remember way back in term 1 with the abdominal thrust or the Heimlich maneuver, whichever way they taught it to you, the term for it, right? If you remember, we don't do that until they're unable to speak. Because they're unable to speak, that indicates there's a full obstruction, right? So if this person gets to where they're unable to speak, then basically we're in a medical emergency with this. That makes sense to you. With croup, that isn't happening. They don't really have inflammation of the epiglottis, so they can get a real hoarse voice with a barking cough. And of course, based on scan secretions, they're unable to swallow. They drool, drooling of saliva, basically. And once again, if you think the epiglottis is swelling, that's going to create issues not only with the airway, but also with passage of stuff into the esophagus. Is that, so it's just sort of understanding the anatomy physiology a little bit of what's going on here, and you can figure out all the different problems that are going to develop, and then basically you should be able to start thinking, what are major interventions that I may have to do for this patient, because it go everything from mild interventions all the way up to life-saving measures for the person with the epiglottitis. So just things, just trying to work on the thought process, because when you do NCLEX, they're looking to see, do you have the thought process in there to appropriately care for your patients and keep them safe, if that makes sense. The other thing with the NCLEX, I don't know if they say or not, when you get ready to NCLEX, when they write NCLEX questions, they only write it with one thing in mind. Does anybody know what that might be?
Check your safety.
Okay. Yeah, well, they're always looking to see if you're going to be safe and efficient. But basically, when they write an NCLEX question, basically when they're writing that question, they're writing it because they want to write a question that when you read that question, you have no idea what the answer is going to be, but you have the knowledge to find the right answer. So, it's not going, when you do the NCLEX, it's not going to be like regurgitation of, I studied, so, I remembered what it said in the book or whatever. So, they're going to write a question just like that. I can just go to memory recall and regurgitate it onto the test. They're testing you to see, do you have that critical thinking? Are you able to figure out what's going on in the question in order to be able to get to the right answer in your options? So, and that's why I say it's always in the thought process. Sometimes it takes a little bit of time. You have to sort of work those questions to get to the right answer. So anyhow, with the acute epiglottitis, basically we have the expected findings. So these are what we would expect to see, right? So they can have stridor, drooling, high fever, dysphagia. So if you think difficulty swallowing, dyspnea, difficulty breathing, they can have a muffled frog-like voice, tachypnea, right? Tachycardia, tripod position. So if you think about that real quick, if we have a respiratory problem, right? The early signs that we have an issue happening will be tachypnea, tachycardia. Also, probably we're going to have restlessness or irritability that will also come into play with this. And those will all be early signs that we're having a problem. Now, if you remember the tripod position, basically that's telling you that somebody definitely has a problem. So the tripod, remember, that's why I got the legs spread apart, their hands are on their knees, or sort of lean forward. Also the orthopic position where they lean forward and have their arms spread out. So you'll see people that have difficulty with respirations, they will do that to try and help them breathe better. So basically, if somebody's assuming a tripod position, that indicates that they're having difficulty breathing and we need to intervene. Basically, we're going to have to check and make sure the airway's open, gets oxygen on them, and stuff of that nature. And you'll find out tripod position, if you think about it. You're going to, people that have COPD, people that have asthma, a lot of times people are having difficulty breathing. This is a position that they will assume naturally even though we will teach them that if they have those conditions to help them breathe when they're having an exacerbation of symptoms. So therapeutic procedures and medications. So basically here, like here, if they're unable to speak, they're having great difficulty breathing and stuff, then it's possible they're going to intubate them. So they'll probably put an endotracheal tube down through the mouth. If it's real severe, they may have to do a tracheostomy on the patient and support respiratory functions. They're going to do, if you see, a lateral neck radiograph. So basically they're going to take an x-ray of the neck. Corticosteroids, they're going to use those. So if you think about it, right, if you look at the word up here, we got epiglottitis, basically, right? So we got itis, which is inflammation. If you think about it, corticosteroids, what are they going to fight? Corticosteroids, what are they going to treat with that?
Inflammation.
Yeah, it's a steroid. So basically, the steroids are going to hopefully reduce inflammation, and that's what they'd want to do in order to keep the airway open to try and prevent it from getting more severe. And of course, because they're going to be having difficulty breathing and everything else, we're going to put O2 on them, and chances are, if these being young children, they might use a face mask, which then it'd be a higher flow of oxygen, probably over 5 liters. So we're going to have humidification on it. We're going to attach that sterile water to the O2 to provide humidification. Or they may be putting them in an oxygen tent, which they'd also have humidifying in there. Because if you remember, oxygen is very dry. So normally on a nasal cannula, they don't have to use humidification because the oxygen flow is not that high. But once we get up over 4 or 5 liters, that's when they can go to a face mask. And a lot of times they're going to use humidification to make the patient more comfortable so it doesn't dry out their mucous membranes and cause other issues. Then you got antibiotics. So basically, if you watch, we got the droplet precautions for the first 24 hours after IV antibiotic initiated. So if you think with this, basically we're going to have droplet precautions. So remember, if we're going to be working with this child, we're going to have to wear eye shields. We're going to have to wear a mask to protect us from droplet spread. It's going to be droplet isolation. And then, of course, if you think about it, the child's having great difficulty breathing and everything else, and you know the child's going to be very frightened. So you can't come in there in a panic mode with what you're seeing going on with the child. You got to be cool, calm, and collect to work with these children, because if you're cool, calm, and collect, that will also help relax the child so they're not as frightened and not as panicked about what's happening. Because whatever you're presenting to the patient's going to magnify that 100-fold. So I always say when we come in there, even though we know it's very bad and we may be fighting to save someone's life, we can't be looking like we're in a panic mode. When I said, like I said, I worked in oncology for 11 and a half years. We're good for about 12 anaphylactic reactions a year. Sometimes more, sometimes less. I can't tell you how many times I had a patient, I was going into full-blown anaphylactic reaction. We're a freestanding clinic, so we're not part of a hospital, so we have to call 911 to get them to a hospital. We're working on with all our emergency meds that we have and IVs and everything else. And, I'd be trying to go 100 miles an hour inside, and I felt like I was moving backwards outside. But I always stay cool and calm on the outside and reassuring to the patients. And I can't tell you how many times patients came back that would tell me that they thought that they were gone, but the way I was acting and the way I was working with them, they knew that they were going to make it. And it was because I didn't allow myself to freak out, because I had the patient going southbound on a northbound mule. So, you got to be very careful when you're out there working. And of course, as you're probably noticing, what I do is I don't teach just for NCLEX. I also am working on it so that when you're out in the field, hopefully you'll be the best that you can be when you're out there actually working with your license. So basically our interventions, so one of the things, encourage position of comfort. So, a lot of times we may always think of positions we want to put them in, but a lot of times the patient may assume a position where they're the most comfortable at. And as long as it's not going to be detrimental to what's going on with them, we'll let the patient assume that position if that's what provides comfort to them. Like it says, droplet isolation. So when we go in there, remember you want to wear the gown, the mask, and eye protection, an eye shield or eye goggles to protect you from the droplets from coughing or whatever in there. And of course, I know they always say droplet protection. You know, we wear droplet protection when we come within 3 feet of the client. My thing, I always say, sit there, just, it doesn't matter. You walk in the room, be suited up for it, because you don't have any idea where those droplets have landed. And the last thing you want to do is to get in contact with it, and now you end up getting it, or you take it home and give it to a family member. Provide calm reassurance to a child and caregiver, and monitor O2 sats. Now, the thing here is, I know that we're talking about children and stuff, but if you watch, a lot of our interventions are the same interventions that we would do for an adult, right? Everybody, and that's why I've started off with children, because I've had so many people do it, and they'll tell me they got a lot of pediatric questions and OB questions on their NCLEX, and that was because it was an area of their weekend, but they always stressed over it. And it's like, if you think about it, when you guys took OB and Peds in term 4, right, they didn't cover every possible condition that a child could have, because, you know, heart failure is heart failure, right? Respiratory distress is respiratory distress. Pneumonia is pneumonia, right? The only difference with children is they go critical faster. And then the main difference is like when you have the newborn up to the neonate, the first year of life, right? Because they got the fontanelles and stuff that might give us information about other conditions. So, you know, don't stress out when you get pediatric questions, just work through them. So also, we need to ensure intubation equipment is at bedside. So if you watch, that's a big one. Basically, because if the child goes into respiratory distress, especially if the epiglottis swells up and closes off the airway completely, they're not going to take this child into surgery to trach them or intubate them. Basically, they're going to be doing it right bedside. They're going to do it right in the room, you know. So they may stick an ET tube an ET tube right down the throat, the endotracheal tube, or they may have to do a tracheostomy right there at the bedside. Do not put anything in the mouth, so no tongue depressors, no culture swabs, because we don't want to do anything else that's going to aggravate it and make it worse. So now we got acute laryngotracheal bronchitis. So if you just watch, you know, you got the larynx, the trachea, and the bronchioles can be involved in this. It's going to be inflammation of these areas, right? So basically, that's why I say a lot of times, if you just look at the words sometimes and break it apart. Laryngo, right? Larynx. Tracheal is the trachea, right? And of course, you got bronchitis is inflammation, you know, going to be the bronchioles down in the lungs, right? So basically with this, so this is a croup syndrome. This is another part of what could be with croup. So you got the viral, so RSV, influenza A and B can cause this to happen. Mycoplasma, pneumonias, measles, and para-influenza types 1, 2, and 3. I'll let you know on when you're in collecting and stuff, they're not going to probably be asking you, you know, what actually caused this, right? If you think about it, a lot of times they're going to be testing you on your knowledge of what you're supposed to do with the patient, but you need to be familiar with the A&P and stuff like that so you can figure it out. Because if you watch a lot of times, you know, your A&P basically is what is normal, and anytime somebody has a problem, our main thing that we want to do is we want to take them back to baseline or as close to normal as we can get the child. But if you don't know where normal is, then you don't really know where you're trying to go with your interventions. So anyhow, like it says here, age most affected, children younger than 2. So onset of symptoms is gradual and expected findings. So once again, we got inspiratory stridor. So that means when they are inhaling, we hear that high-pitched shrill that they can get. Of course, they can have a barking, brassy cough, hoarseness, restlessness, irritability, substernal retractions, low-grade fever, basically, and the symptoms tend to be worse at night. So if you think about the substernal retractions, that's when if you ever, I don't know if you've ever seen them or not, They can be quite scary in a child. That always freaks me out when I see it. I don't work pediatrics, but occasionally I've gotten stuck with it, basically. But basically, you'll literally watch the chest. Their chest will actually sink in through the ribs, so you'll be able to see all the ribs. And normally, the abdomen tucks up underneath the stomach because they're trying to pull air in because they can't. So it's just sort of a picture with it. So going with some of the stuff, slow onset, barking cough, growing at night in fall and winter, can progress to hypoxic states, may have slight temperature, typically under 102, basically restlessness, suprasternal retractions, increased respiratory rate. And of course, if you think about it with it, anytime we have a respiratory problem, most of the times it's that we're not getting enough oxygen into the body. We're going to see tachypnea. We're going to see the respiratory rate go up. And also remember, when the respiratory rate goes up, generally as a rule, what other rate's going to go up as well? Because they don't have it listed.
Respiratory.
Because if I have the respiratory system, what's the other system that's closely attached to the respiratory system?
The heart rate.
Yeah, the cardiac system, right? So typically, not always, but a majority of the times, the respiratory rate goes up, the cardiac rate's going to go up because the respiratory rate's going up because they can't get oxygen in, they can't get the gas exchange to happen, so respiration's increased, and because the body's not getting enough oxygen, right, the heart rate's going to increase as well, trying to circulate more blood, trying to move more oxygen around the body, right? So, and then, typically remember when we have respiratory conditions, basically, and even when we have cardiac conditions, and there's other conditions too, but, increased respiratory rate, increased cardiac rate, anxiety, or irritability, right, or restlessness, irritability, and even anxiety, those tend to be really early signs for a lot of different problems. And so, if you're taking care of a patient, they being relatively comfortable, not having too much problems, all of a sudden you come in and now you see they got an increased respiratory rate, increased cardiac rate, they're restless, or they're snapping at you. You need to stop and take a look at that patient because something has changed, something's happening, and if you can figure it out at that point in time, hopefully you can stop it from where it gets really advanced. Now we might have to be in a life-saving mode with the patient, calling in rapid response teams or code blues and all that other stuff. So therapeutic procedures and medications. So basically cool air. So take outside, basically if you can, cool mist for mild croup. So we want to get, a vaporizer basically in the room, cool mist vaporizer in the rooms to help put moisture in the air. It makes it easier for them to breathe. Once again, you see steroids, and they're going to work. They do a lot of different things to the body, but we want to make sure it's getting enough fluids, so they maybe want to increase oral fluids, or they may be putting IV fluids in them if they need to. Nebulized epinephrine as ordered. So if you think the nebulizer treatment, if you think, I don't know if you've ever been in the urgent care doctor's office or whatever, because you might have had bronchitis real bad or something, basically, and you're coughing and hacking, you're not breathing super great, and they get out that little corrugated tube, the little T-tube is corrugated, and they have that little bowl underneath it, basically, excuse me, normally they put albuterol in it. Here they're going to put epinephrine in it, and they breathe it in, and then when they breathe it back out, if you've ever had it through that corrugated tube, then it comes out like a mist at the end. That's what the nebulized, and of course they could put them in a tent with nebulized air going in there, so it fills the tent up with that, so the child will breathe it in if they're not capable of using a nebulizer. Basically here with our nursing interventions, so one, if you think about it, any of our patients that are in distress, any of our patients that are sick, right, we're going to be monitoring vital signs, including the pulse ox. If you think about it, that's standard on all patients, so that's something you shouldn't have to think about, right? And then, of course, be alert to signs of impending respiratory obstruction. So like I said, respiratory issues, you see it, there's tachypnea, tachycardia, so increased respirations, increased cardiac rate. We can have chest contractions, nasal flaring, and restlessness. So the early signs that we'd want to catch would be tachypnea signs, retraction, and nasal flaring. These are real bad signs, and these are late signs, which means we missed the beginning signs. So, and you have to be careful because if NCLEX asks you what would be an early sign or symptom of something, right? Or what would be the early sign of a condition or whatever like that? Well, if you pick an option that would be a later sign, then it would be wrong. So, you sort of need to know the difference of what would I expect to see early versus what would be a later sign in the condition, right? And of course, nasal flaring, I already explained the chest retractions. Nasal flaring, that's where the nostrils are going to pop out. They almost look like little trumpets. And when they're in respiratory distress, they can pop out really, really big. So, and if we see that, basically, the chest retractions and we see nasal flaring, that's a good indicator that they're going into respiratory distress. That's something that we need to report right away, and we have to start working with that child immediately to prevent them from going into full respiratory distress. Okay, encourage caregivers to stay with and hold child to calm, provide reassurance. Excuse me. So if you think about it, you shouldn't have to think about that at all, because anytime you have a patient in distress, do you ever leave the room?
No.
What do you think? Would you walk out of the room if your patient's in distress?
No.
No, we don't ever leave the patient in distress alone, right? We use the call bell in the room, or the call light basically, or the call intercom if we have to, or if we have to, we'll holler out of the room to get somebody to come in and help us, but we're not going to leave that person alone. So, you shouldn't have to think about that one. We always stay with, it doesn't matter if it's an adult or a child. The only difference here is, like it says, these are young children here. So basically, if we can, we'll try and hold them to calm them down. Now we got acute spasmodic laryngitis. Okay, so once again, we got the inflammation of the larynx, and it's spasmodic, so it's spasming, so it can clamp down and release. So, and when it clamps down, it can stop airflow completely. This is just sort of a picture here, and if you think about it, the larynx is the larynx, so if you think about it, it's where your voice box is, your Adam's apple wall. And if you watch, here's your epiglottis. Of course, we talked about the inflammation of the epiglottis, that's up here. Down here is the glottis, and here's my vocal cords. So if this area swells up, then it can close off the air. It can close off the air passageway completely. So we need to be very astute with monitoring these patients. So, like it says, it's viral. It could be possibly an allergy related. So they could be having an allergy or allergic reaction, basically to something that's out in the air or something they've eaten. Ages basically typically 1 to 3. Basically onset, child goes to bed well, midnight or twilight, croup awakens the child. So expected findings, once again, awake suddenly with dyspnea, barking, metallic cough, stridor, hoarseness, and restlessness. Symptoms disappear during the day, and it's recurrent. So, during the day, they're doing good, and then at the night, this happens again. So the procedures and medications, so once again, cool mist, steroids, racemic, basically epinephrine, and supportive care. So nursing interventions, basically, typically this one here, most of the times, it's like it says, usually managed at home. But if you think about it, they may call a nurse line, they may have come into the emergency room, and we're going to have to educate the parents so then they take the child back home, they know what to do. So, cool mist vaporizer, and of course, encourage quiet activity. We don't want to get all worked up. All right. I'm not going too fast for you guys, am I? Because I'm just, I figure a lot of this is probably there, so it should be a review. if I go too fast, let me know. Same thing, if you think I'm going too slow, let me know. I try to find right in between pace, hopefully. So anyhow, the younger child, they're more susceptible and they're more susceptible and serious to conditions. So we've got acute gastrointestinal infections. So poor underlying poor health, malnutrition, immunocompromised environment. So it could be crowded, poor sanitation, lack of access to clean water. So this is what could cause acute gastrointestinal infections. And if you think about it, if I have a problem with the GI tract, what is my concern? Anybody got an idea?
Malnourishment or dehydration.
There you go. Those are the two big ones, right? Malnourished and dehydration, because think what the primary function of the GI tract is, right? So if you do that, when we talk about gastrointestinal, yeah, there's a lot of different things can go wrong in the GI tract. But we get very concerned with nutrition and hydration with this happening. And of course, if they get malnourished, that can lead to a lot of other stuff, right? Anemia, they can become immunocompromised where they can get sick easier and stuff of that nature. And of course, if they can't get fluids into them, then they dehydrate, and that creates another whole set of problems, right? So anyhow, basically here, it's a lack of knowledge, poor food preparations and storage, inadequate hand hygiene. And you guys think, most people think, well, how in the world would you get poor food preparations? Well, you got to remember, some people just aren't taught right. I've seen people that they go and get pork or they got chicken or whatever, and they can leave it on the counter for 3, 4, 5 hours before they actually go to cook it. Drives me crazy. I used to have to go and try and educate them on that, but it's like, well, my mother did this, my grandmother did it, and then I'm doing it, and it's like, okay, but you're opening yourselves up to having some, serious infections or GI problems from doing that. So, it happens out there. So yeah, it can be exacerbated by antibiotics and other medication therapies. So expected findings. So, we got the GI infection. So if you think about it, a lot of times, if we eat something that is not good for the GI system, a lot of times what will happen, peristalsis increases to try and get it out of the body so we can have diarrhea. And with the stomach and stuff, a lot of times, basically it will cause vomiting because the body's trying to expel this infectious organism that's getting into it. You got malice, which is a severe form of fatigue. They can have fever, poor appetite, dehydration, and weight loss. And of course, you think the weight loss is coming from malnutrition, right? Mm-hmm. So stool examination, culture is positive for ova, parasites, or bacteria. So, and these are things we have to watch out because these are some of the major invaders. Now, one of the things going to happen is a lot of times, I think it'll come up, but they test for ova in the stools. Remember, for ova testing, they normally will take 3 specimens. So they're going to do 3 stool specimens, but they're 3 separate specimens. So they'd have a bowel movement, and I take a specimen out of that, send it to the lab, then I wait for the next bowel movement. When they have that, I'll take another specimen, send it to the lab, and then when they have a third bowel movement, I'll take a specimen out of that and send it to the lab. It's not 3 specimens out of one stool. So just, that falls into my ova and parasites when they do stool specimens for that. That's how that would be done. And then you got your ELSA, basically enzyme-linked immunosorbent assay, basically positive for the retrovirus or diarrhea, if I got that one close. So laboratory tests, diagnostic procedures, like examination for blood, ova, and parasites. If we're looking for blood, they may get a stool specimen and send it to the lab, look for the blood, or they could have you do a hemocolt slide, basically to check and see if it turns positive for blood. Most of the time, it's going to have you send it to the lab nowadays. Stool cultures for bacteria, ELSA for the retrovirus, CBC, and electrolytes. So if you watch CBC and electrolytes, some electrolytes are going to show me basically a lot, basically as a person getting enough of the different electrolytes in the body, And of course the CDC, they can check for anemia and stuff of that nature, because if they're not getting appropriate nutrition in their diet, then they're not going to have appropriate arms, so they could be anemic, basically, and stuff. And also because the white cells can be impacted because of low nutrition, that can also put them at risk for infections. Therapeutic procedures and medications. So they got antimicrobials, antibiotics, and antiparasitics, basically. And then, of course, you got your antipyretics for fever. Antiemetics are used for vomiting, basically, if they're unable to tolerate anything orally. So basically, meaning you give them something orally, they vomit it back up, they can give them antiemetics. And of course, IV fluids only if unable to tolerate oral fluids. So oral anemetics, so you got promethazine and metoclopramide should not be routinely administered to children due to the potential for adverse effects. And of course, it has the adverse effects here. So these are things that we need to be there. Remember, these are the older type of antiemetics. The newer ones are not going to cause the same issues. So basically here, nursing interventions provide oral rehydration therapy, administer 5 to 10 mLs every 1 to 5 minutes. And so, we're going to want them to be drinking fluids. Vomiting is not a contraindication unless severe. After rehydration, alternate with water, breast milk, and lactose-free formula. So, and then of course reintroduce a normal diet as soon as possible, lessens severity of illness, and improves weight gain. Give me just 1 second, I'll be right back. Okay, so anyhow, okay, there we go, excuse me, okay. So yeah, our interventions is going to gastrointestinal infections, so we're going to do daily weights. So if you think about weight is the best indicator of fluid gain and losses. So if you remember, when we do daily weights on patients, we're not looking at nutritional status, we are looking at fluid balance in the body. Typically, if we're doing weekly weights, that is looking at nutritional value to see if the patient's gaining weight from week to week to find out if nutritionally they're doing it. So we have to weigh the patient every day to check for fluid gains. So what is the conversion? Basically, if I'm looking at the weight, the patient weighed 150 yesterday, I weigh him today, he now weighs 155. What would be the conversion so I know how much fluid he's gained or lost? In this case, be gained. Do you know? Okay. So my conversion basically is going to be 1 liter of fluid equals 1 kilo, 2.2 pounds. Okay? Excuse me, I should have did kilos. But anyhow, 1 kilo. And of course, the thing about a kilo is 2.2 pounds. So for every 2.2 pounds, basically, or 1 kilo, basically the person would have retained 1 liter of fluid. So if the person gained 5 pounds, I know approximately that they would have gained probably somewhere around 5 liters. He would have gained somewhere around 2.25, 2.5 liters of fluid would have been how much fluid they would have gained or retained in that period of time. Does that make sense?
Mm-hmm.
So that's my conversion there, because then if I have to figure out, they sit there and say the patient gained, 1 kilogram of weight, how much fluid is he retaining? Well, I'd have to know that they retained 1 liter fluid. Same thing if the person lost one kilo, basically, then I would know that the patient lost 1 liter of fluid. So you sort of have to know the conversion, because if you don't, then doing daily weights doesn't do you any good, because then you're not able to determine how much fluid they're retaining or losing. Hope that makes sense to you.
Mm-hmm.
So anyhow, monitor electrolytes, blood glucose, and acid-base balance. And of course, if you think about it, basically acid-base balance will be affected by the GI system. And of course, if you think about it, this will be metabolic. That's the one thing when we're talking about the croups and the croup syndromes and all. I say that because if you think about it with them, anytime I have a breathing difficulty, I'm going to have a problem with my acid-base balance, and it's going to be respiratory related. So, if we have problems breathing, then we go into respiratory acidosis, right? If we have a problem within the body from the kidneys, GI system, or whatever, that becomes metabolic, and a lot of times they can go into acidosis from it, so that would be metabolic acidosis. So carefully monitor intake and output. And of course, if you think about it, we should be doing that with all of our patients as well. And do not measure temperature rectally. So we don't do that very often anymore, but NCLEX could throw it in there. And so just remember with this here, we're not going to do any rectal temperatures with this person. Of course, these are children. So, and actually with children, remember most of the times now, with children back in the day, they used to do rectal temperatures all the time. And on a newborn, they don't ever do a rectal temperature on a newborn. When they got older, they could. Most of the times they take the temperature axillary, basically on it, or if they got tympanic, tympanic or the forehead thermometers now if they have out, they will use those, but they won't do rectal. So if hospitalization is required, give nothing by mouth, prepare to administer parenteral fluid. So basically, if you think about parenteral, right? Parenteral is around the GI tract. So they're having if they're having a GI issue in here, they're not going to introduce, and they're NPOing the child, right? Giving it nothing by mouth, then they're not going to introduce enteral feedings, right? They're not going to do a feeding tube, they're not going to put an NG tube in to feed them, because that'll just agitate it more. So they're going to use parenteral feedings or parenteral fluids. So they're going to do it by IV in order to give the child fluid, and also nutrition if they need to. They'll give them TPN, total parenteral nutrition. Plan education, observe signs of dehydration by counting wet diapers and voidings. So seek medical attention if dehydration is expected, especially for infants due to the risk for hypovolemic shock, basically. So, and of course, hypovolemic shock, that's where they're not having enough fluid in the vascular space, and that could cause a full cardiac collapse, which then could basically kill the child. So with this, we need to be watching. Now, with the infant, basically here, you'll find out if, I don't know if you got to, deal with the nurseries and the pediatric patients and stuff of that nature, but normally in hospitals now where they do it, they normally have the diapers and they give the weight of the diaper. So what you have to do is you weigh the diaper, you subtract the weight of the diaper, and then that gives you how much fluid is in the diaper, and then that's how you're able to start calculating what the fluid output is, and also we count how many diapers they're doing at a specific period of time. So reinforce the importance of hand hygiene, proper food storage, and clean water. So then we got gastrointestinal infections of children, basically the E. coli. I'll do it that way. You don't want to hear me try and pronounce the word. So here they can have watery, then bloody diarrhea. So this is not a good thing. Abdominal cramping can develop hemolytic uremic syndrome. So transmission, basically bacterial contaminated food, beef, milk, fresh produce, water, and person to person. So if you think about it here, most of the times it's contaminated food, or basically that means it can have bacteria and stuff in it. So this is just sort of showing a little bit with it, basically, so you can see just a picture, where to get stomach aches, diarrhea, blood in the stools, vomiting, fevers, and stuff. So, and it's just another one coming in with it. And of course, basically, if you think about it here, it can destroy the red blood cells, basically. And of course, destroys red blood cells, that then they're going to be anemic. And of course, because of these cell destructions and all, basically blocks the kidneys filtering system. Basically, it clogs up the kidneys, and then they start having kidney issues and they can go into renal failure. So basically here, like it says, manifestations, bacterial, basically they get mild watery diarrhea, can develop pseudomembranous colitis. So basically the colon really large. Transmission associated with alteration in normal intestinal flora by antibiotics. So this is C. diff, Clostridium difficile. So this is another one. And most of the times, if you think, with C. diff, this is a nosocomial type infection that happens, basically. So a lot of times this is hospital acquired, unfortunately. And basically a lot of times what it is they're using a lot of antibiotics on the patient, and if they don't monitor it closely, then the patient can develop C. diff, and then they got a big problem. These are some of the ones, so some of the different things I was able to pull up the show. Also, too, I'll remember when we're done, I'll put my email into the chat box, and if you want to copy the PowerPoint, then all you have to do is just email me. I'll attach it to your email and I'll send it back to you. I don't have a problem getting the PowerPoint out if you think they will help you or not. So they got salmonella, basically. So once again, this is another GI one. So basically it's bacterial, mild to severe nausea and vomiting, abdominal cramping, and of course, once again, bloody diarrhea. Basically, it happens from undercooked meat, eggs, poultry, and it can also be person-to-person contact. And of course, with this here salmonella and all, a lot of times people think of chicken, people think of eggs, but it can also be in the meat. And if you watch the news and all, you've seen that even they've had that even happen with the romaine lettuce and stuff like that. So, it can happen. Once again, it's just some of the ones that come out showing, once again, diarrhea, stomach pain, nausea, vomiting, fever, headache. So these are the common signs of it. So, and then of course we got pinworm, basically Heminic, I'll let you do my tongue's not going to spin on the word. I can only pronounce it, but tonight I don't seem to. So these are intestinal worms. They can grow quite long in the intestine. And the problem with the intestinal worms like this a lot of times is the child will start becoming malnourished, because what it is, the worms will start eating the nutrients that should actually go to the child. So one of the manifestations with, they can have perianal itching and enuresis. So transmission, basically fecal oral. So it's just sort of showing the way they can run around. Now, one thing I'll say with it, I think I got a question. I'm trying to remember way back in my NCLEX. Most of the ones I didn't know the answers, but I got out real good on it. So I did good on my NCLEX. But I think I had one where it was talking about, at night you shine the light down on the rectum and you see something coming out of rectum sort of wiggling. What would you do about it? and basically just leave it alone. When it's coming out, if you see it, they can come out through the rectum a little bit. You don't want to pull on it, trying to pull it out, because you won't, because it breaks off and then it creates other problems with it. That's just something that we would have to report to our charge nurse or to the doctor, whoever it is that we're reporting to, depending upon where we're working. So, and the bad thing with it, a lot of times, the eggs can be basically get in, like it says, we ingest it here. And basically what happens is once they get into the intestinal, they lay eggs, so they grow more worms. And of course, when they have a bowel movement and all, they get the eggs out. Remember, ovas, that's your eggs. And, excuse me, so those eggs are in the feces and all. Basically, if somebody doesn't wash their hands appropriately or whatever, and then when they're eating, they can reintroduce the eggs back into their GI tract, and then they'll just lay in the GI tract, hatch, and then continue to grow, and then they can get a bunch of worms. So here's a picture of one of the GI worms, so as you can see. So yeah, gastrointestinal infections, once again, the Giardia lamblia, if I get that in close. So this one, once again, you got diarrhea, greasy stools, abdominal cramping, vomiting, and anorexia. Now, if you look at this a lot of times, and I know we try and catch commonalities, and you'll see, if you remember your different systems and you watch, each system has commonalities of what we see happening, right? So if you watch the GI tract, we're getting the abdominal tract, we're getting the abdominal cramping, we're getting the vomiting, getting diarrhea going on. So, here with this one, we get greasy stools, with some of the others, we get bloody stools. Other ones are watery stools. But if you watch it, typically we see the diarrhea, vomiting, abdominal cramps and stuff. These are common signs and symptoms of a lot of GI disorders. So now transmission, parasitic, comes from, once again, contaminated food, water, and animals, and of course, person to person. So once again, this is just sort of showing basically how it can go around a little bit with, like I said, I'm not going to read through it. You can sort of glance through and see how it gets going around in there. But if you watch it, basically it enters through the mouth, which is the entrance to the GI tract and stuff. And this is why, if you think about the importance hand washing, because it's our #1 defense against infections. So, depending upon where they come from, it may not be common knowledge. And, that's why even with COVID, when we had the COVID stuff and everybody's in lockdown, and even today with the COVID keep going around and around and around, right? They always talk and tell everybody, make sure you're washing your hands frequently, right? Don't be putting your hands up to your eyes and stuff like that, so you can minimize the chances of getting it. So it's the same thing like here, with this stuff as well. And then also making sure that what we're eating and putting into our mouth and all is prepared appropriately so we don't have the problems. So this is just sort of a picture, a little bit of it going on with a little bit of child. And once again, it's showing you the different types of stuff. And typically our water supply is sort of is safe here. But also if you watch at it, they can have outbreaks, because just like now on the East Coast, the hurricanes hitting, all the flooding and everything else, the water systems are compromised, and that's why they're using, bottled water and all. But, if somebody's really thirsty there and they're stranded and they can't get there, they may try and make do with whatever the water is they have, and so then they could be prone to having these types of issues as well. So now you got the retrovirus. So most common cause of diarrhea, most common cause of diarrhea in children younger than 5. So they can have a mild to moderate fever, vomiting followed by watery diarrhea. Transmission basically can be viral, often nosocomial. So once again, remember nosocomial, that's hospital acquired. So they got it in the hospital, which is not good. And it's fecal oral route. So just some of the stuff once again, just the slide there, going with it. so that you can see on there, and of course abdominal pains, which you can see. Dehydration, and of course, because GI tract, they get the problem, they get diarrhea, and they got vomiting going on and stuff. We know that's going to impact hydration. We also know it's going to impact nutrition, and also too, that can impact our acid-base balance within the body, depending upon which one they're having. If they have a lot of vomiting, then basically they're going to lose a lot of acid, so then they can go into alkalosis. If they have a lot of diarrhea, then they can lose a lot of the bicarbs and stuff that are in there, and so basically they could go into acidosis. So we got to watch out what's going on. So diarrhea, basically fruit juice, carbonated drinks, gelatin, caffeine, broth, and sports drinks do not help diarrhea and vomit. So these are not things that we want to give patients that are having diarrhea and vomiting. Also, if you look at them, basically they don't have any real nutritional diet. We always learned about the brat diet for diarrhea: bananas, rice, applesauce, tea or toast, but they don't really do that too much because if you do it short term, it's not a problem, but you can't stay like that because it doesn't have much nutritional value. And so that can cause problems with the electrolyte balance and the nutritional status within the patient. So here we go with hyperbiliruria. Yeah, there we go. So anyhow, it's a byproduct basically of the breakdown of red blood cells. So when the immune liver is unable to process bilirubin for excretion, excessive amounts accumulate primarily in the sclera, nails, and skin, manifesting as jaundice. I'm sure you probably remember this one from term 4. There's a couple of causes of it, but in this one, basically a lot of times they're born, they have this. A lot of times if it's not a physical issue, a condition that they have, this is when they're going to put them into phototherapy for a little bit. If you think about it, right, the bilirubin is the breakdown of the red blood cells, like it says, and the way a lot of times the way it gets done is the liver packages it up to get out of the body, and bilirubin is one of the components that is used to make bile. So the liver produces bile, sends it up to the gallbladder, right, and then of course that's used to go down into the duodenum basically to help emulsify fats so that the body can break them down further to get them into the body, right? So here they got a problem, so they're keeping too much bilirubin in the body, and of course they get jaundice. So contributing factors, so one, prematurity, breastfeeding, liver compromise, decreased intake, mother's diabetes, Native American or Asian descent, birth injury that causes bruising or hematomas, hemolytic disease, siblings who have a history of hyperbiliruria. Yeah, there we go. And Rh negative mothers. So these are some of the contributing factors. Remember when you see contributing factors, the other term is risk factors. Some of my slides I'll put contributing/risk factors before you get it there, because I found out that when I was teaching, because I taught term 2, I've taught every term in the program, but I found out sometimes, when they word something differently, you're not used to seeing it. Now you're scratching your head and going, what's a contributing factor? If you're not thinking about it, and when you're testing, you got the stress of the testing and everything else, and all of a sudden you got a word you're not super familiar with, and sometimes that just helps cloud your thinking. So when you see contributing factor, it just means risk factors. So these are all things to put the person at risk for developing this. So expected findings, like it says, jaundice based on the sclera, the white of the eyes, the nails, or skin, occurs when unconjunctivated bilirubin levels exceed 5 milligrams per deciliter. And of course, you can see the yellows of the sclera and the skin, basically, and here they got it on the fingernails. So laboratory tests, so serum bilirubin, they do a Coombs direct and indirect, and a transcutaneous biorubinometry. Yeah, if I get that one pronounced right. Like I said, you'll find out I don't pronounce all the medical terms appropriately. Unfortunately, I didn't learn phonics, so a lot of times I have to look at it and sort of take a guess of how I think it gets pronounced. but I still got my license. So if you have the same problem, right, you're on the right track. So the procedures basically and medication. So like I said, if there isn't a medical reasoning for, liver dysfunction or whatever that's actually causing it, then phototherapy is used to resolve it. They can have exchange transfusion for dangerously high bilirubin levels, immunoglobulins of caused by blood incompatibility, so that'd be like gout. And then, of course, they got the 10 mesylpurinian, basically, so that prevents bilirubin formation. Could do depending upon what's going on. But most common, what they do, light therapy. And of course, if you watch here with the light on here, we got to check baby temperature auxiliary at regular intervals to make sure every few hours so that they don't overheat. So we're going to cover their eyes. We want them undressed. So with male babies, basically we want to put a diaper on to protect the genitalia with them. So there's our RH, basically with the mom, and with it. So basically, the big thing, remember with the RH incompatibility, remember with the mom, the Rowe, and that's not really going to help the baby that she's pregnant with at the current time. They give it at week, what is it? I think it's week 26, and then after delivery, to that, and we'll have baby. What will happen? You have to be RH positive, that her immune system will attack the fetus and destroy it. Hydration, so we want to make sure that the mother is, the infant is feeding, basically, and especially milk. Remember, breast milk is the best form of nutrients for a newborn and a neonate. Basically, so we need to make sure that they're feeding appropriately so that the child's getting all the hydration and nutrients that it needs. Initiate breastfeeding within 1 hour of birth and encourage rooming in. Of course, all rooming in is basically, the mother, they keep the newborn in the room with the mom as much as possible, and hopefully the mom will be feeding at the appropriate intervals, and also bonding with the child at that point in time. So for infants under phototherapy, and I know NCLEX will probably ask something about phototherapy and about this condition. So basically, we want to expose as much skin as possible to the light. Like I said, though, if it's a male baby, we want them to have a diaper on to protect his genitalia, because remember with the males, the genitalia sits outside the body. With the females, the genitalia sits inside the body. So basically ensure that an oblique mask is in place over the infant's eyes. So that just means no light can get, oblique means no light gets through it. So we want to do that to protect the eyes. Remove the mask when the infant is taken out from under the light, and monitor for temperature instability. So because this lighting can cause newborn to have an increased body temperature. So that's why we'll do auxiliary temperatures, every, hour, 2 hours, whatever, just to make sure that the infant is not getting overheated. And if they are getting heated up, then we'll stop the light therapy, you let their body cool down before we reinitiate it. Reinforce the importance of adequate intake. So if you think about it with light and all that stuff, basically they can dehydrate. Leave the infant under the light as much as possible with the mask in place. Explain how to monitor for jaundice and to notify the provider if it worsens. And explain the importance of monitoring urinary and stool output. Give me just 1 second. Okay, sorry about that. Like I said, of course, you came on later. My wife has advanced Alzheimer's, so she comes into the room periodically. So that's why when I take these quick little breaks, it's normally because she's come into the room. So I have to talk to her for a second and she'll go back out of the room. So sorry about that. So anyhow, reinforce the importance of adequate intake. So, we want to make sure the mother is feeding the infant appropriately, and also we want to make sure that the infant is actually feeding appropriately. Leave the infant under light, like it says, yes, mask in place. So yeah, we did that. Explain how to monitor for jaundice, okay, and importance of monitoring urinary and stool output. Okay, so we got acute appendicitis. So, and if you remember back to term 2, you learned about appendicitis. So here they're just talking about it with the child, but the appendix is the appendix, right? So inflammation of the variform appendix caused by obstruction due to, basically it should be fecal or hardening stool is the most common. If you remember, the appendix sits in the body on the end of the cecum on the right lower quadrant. And so basically you have to realize that, the fecal matter moves in and out of that. Also, there's a lot of lymphatic tissue in there and parts of the immune system and all that, they believe. And so, if the stool's moving in and out of there, if some of the stool gets hardened, it blocks the opening. Now it closes that off, and then what will happen is that appendix is going to start to swell, and if it swells too much, then it can burst. And now we have a problem. So anyhow, inflamed lymph node tissues following a viral infection or a parasite. So these are a couple of other reasons that it can happen. So like I said, the appendix hangs off the cecum. If you remember, small intestines will connect in here. And like I said, the fecal matter, if you remember here, with the ileocecal valve, this area here, the stool's reliquefied. So the stool moves in and out of the appendix as it's moving up. So if it can harden up, it can occlude the appendix like you see over here, basically. Or if they get an infection, then this can swell up. Because you figure most times with infection, right, we have inflammation of the area where the infection's at. It closes off, and now this stuff cannot move out of here. And of course, what happens is the bacteria grows, and then the appendix starts to swell, which is causing the pain. And of course, it's going to be a surgical intervention to remove it, because if it swells up too much, then it's going to rupture. And now we got a major problem for the patient. So they want to get rid of the appendix before it ruptures. Because once it ruptures, they can go septic, basically, with that. And then they can get peritonitis. If you remember, that's the hardening of the abdominal area because of the infection. And ultimately, the patient can die from it. I know I had my appendix removed. And when they removed my appendix, it was folded over on itself. And the surgeon that removed the appendix didn't realize that it had already ruptured on me. And of course, then I ran a real massive high-grade fever. What was supposed to be 24 hours in the hospital ended up being 2 weeks, because I ended up with super high-grade fever, all infectious disease, all that. They went down, investigated, found the appendix had ruptured. They just didn't see it because it's folded over on itself. And they had put me on they told me it was 3 of the most powerful antibiotics known to man at the time. trying to get all the infection, everything under control, because they were trying to avoid having to take me into surgery to open up my abdomen to try and flush out the abdomen to get all that infectious material out of me. And luckily it worked, but my 24 hours ended up being 2 weeks. So contributing factors, so peak incidence is age 10 years old. Of course, with me, I wasn't into the peak. I was way past that because I think I was in my 40s when that happened. Recent viral infection, intestinal Helminth infection, so that's meaning worms. So fecal abdominal tenderness in the umbilical area progressing to the right lower quadrant. So a lot of times when it starts, it can start in by the umbilicus, by the belly button, or it can start to the left side. And then what it does is it migrates over to the right lower quadrant. So basically the McBurney's point located 2/3 the distance between the umbilicus and the anterior superior iliac crest. Basically, that's where we normally will push in at, and we will look for rebound tenderness. So remember what rebound tenderness is I push in fairly deep, and the patient doesn't have any pain, but then I pull my hands away real quick, and I let the abdomen come back up to where it's supposed to be, and when that happens, the patient has a lot of pain, and that would be a positive sign, basically a positive rebound tenderness, basically, which we'd have to report because that could indicate that they're having appendicitis. Rowe sign basically turns to the right lower quadrant, and that occurs during palpation or percussion of other abdominal quadrants. Of course, nausea, vomiting, anorexia, poor feeding, diarrhea, or constipation. So these are things that can happen a lot of times, They say, they may try and eat something. They feel real nauseated, real full. As it progresses, they can get where they're nauseated, start vomiting. They don't want to eat, anorexia. They don't eat and stuff of that nature. So here is this, and it's just showing you the Bernie's point here. Oh, and this is the area on fast, and when the skin is rebounding back up to go to its normal levels, that's when the patient has the pain. That's why it's called rebound tenderness. So it's just sort of showing here a little bit with what they're doing. They're just using it on the other side. But anyhow, so expected findings. So when they're going to have lethargy. So they can have pain in the right hip when walking, low-grade fever, typically, decreased or absent bowel sounds. Now, decreased or absent bowel sounds, that will be a later sign. That's a bad sign. Tachycardia and tachypnea. Because typically if they're having decreased bowel sounds or they're absent, a lot of times this could indicate that the appendix is already ruptured. And so now they got peritonitis setting in. The other thing that you need to be aware of with appendicitis as well, I don't know if it'll come up or not, but a lot of times the person's going to have this pain in the right lower quadrant, and you'll be within, of course, one thing we don't want to do, we do not want them going to the bathroom, because we don't want them to bear down, to have a bowel movement, because they bear down, that extra pressure, because that'll increase the inner abdominal pressure, that could cause the appendix to rupture. But another bad sign would be if the patient's having the pain and all of a sudden the patient tells you, hey, I don't have the pain anymore, so I can go home. That would be a bad sign because that could indicate that the appendix has already ruptured. And now we got basically pretty much a medical emergency going on. They need to get them into surgery ASAP because they're going to have to go in there to get that out. And they may have to be flushing out the abdomen and everything else and getting them on some very strong antibiotics to stop peritonitis and stuff from setting in. Just things for you to know. So rigid abdomen, that would be a late sign. Like I said, that would be an indicator of peritonitis, meaning the appendix is already ruptured. So if perforation occurs, like I said, okay, there you go. I had it in here anyhow. So basically the appendix ruptures, perforation, that's another word for rupturing. It opened up and dumped its contents into the abdominal cavity. Now the pain is gone. So sudden relief from pain. And then, of course, then what will happen is they're going to get an increase basically in temperature. So their temperature can start going up to 102, 103. And, of course, when they have fevers like that, they're going to get chills. And then they get progressive abdominal distension, tachycardia, tachypnea. And then they can start getting pallor because their body's going to start going into shock. Is everybody doing good out there? Are you guys still with me?
Yes.
Yes, sir. Yes, sir.
Oh, okay. Is this helping you guys?
I believe so.
Yes,
Okay,
thank
good.
you.
Yeah, because as I go on, I'll be bouncing around. I got several that are term 4 starting out with pediatrics because everybody always seems to have issues with that and stuff like that. But as we go through and advance through, I'll be covering stuff from terms 3, terms 2, terms 1, just to stir up all your knowledge to get all back up to the forefront of your head so that when you sit for your NCLEX, you got all your knowledge working for you because, you know, when we haven't done it for a while, it goes into the back recesses and then you can't get to come forward and then you know, that's not good. So anyhow, with the acute appendicitis or lab test, of course, you're going to do a CBC. And of course, basically, if you think about it, appendicitis, got inflammation appendix, you know, so we're going to have the white cells are going to be elevated. And so on the CBC, we're specifically looking for the white blood cell count. So it's going to be greater than 10,000. And of course, if you think about it, right, what's my normal range for my white blood cells?
5,000, 10,000.
Yeah.
5 to 10,000. Yeah, I like to ask questions here and there, so I just wasn't asking too many tonight because I know people don't like to answer me, but I like to do it because it helps make you think to pull the stuff out of your mind. Yeah, 5 to 10,000. So if I have acute appendicitis, if you think about it, not always because we can have it with injury, but most of the times if we have inflammation, a lot of times our immune system will activate to a certain degree. So with this here, with appendicitis, you know, my white blood cells could be 11, 12, 14, 18,000 or more. If the appendix ruptures, then the white blood cell count's going to go through the roof because I guess like my white blood cells, I was running over 30,000 when they were trying to figure out what was going on with me. So, you know, that will give us a good indicator of what's going on. And of course, they'll look at the white blood cell count. And of course, the other thing, and I don't think to put it on here, but also a lot of times they may use a ESR, my erythrocyte sedimentation rate, or they may use a C-reactive protein. I don't know if those labs sound familiar to you or not. They're non-specific labs, but what they do is if those are elevated, my ESR or my C-reactive protein is elevated, it tells us that we have inflammatory responses in the body, which is telling us that the immune system is activated. So typically if the white blood cells go up, you know, most of the times our ESR or C-reactive proteins are going to be elevated as well. They'll do a urinalysis. Of course, they're going to do CT scan or an ultrasound. It could be either one because they're going to go in. A lot of times they do ultrasound because it's fast. To look at the appendix to see if it's inflamed, basically. If it doesn't give a clear-cut picture, then they'll go to a CT scan. So here, unruptured appendix, so our therapeutic procedures, so basically about basically what we're going to do. So IV fluids, IV antibiotics, electrolyte replacement, laparoscopic incision to surgically remove the appendix, and analgesics. So as it goes here, we're going to review pain assessment and continue to monitor, tell the child to point to the area of pain. So remember, we always want to know where the pain is. So basically we have them point so we know, a note change in activity. With appendicitis, the main treatment is going to be surgery. So, of course, we're going to prepare the child for surgery. So remember with the child, the parent has to sign the informed consent or the consent form. The other thing is, remember, if somebody comes into the emergency room, I don't care if it's an adult or if it's a child, because they didn't put it here, but if you understand it, for appendicitis, basically the treatment's going to be surgery, right? Mm-hmm. So if the treatment is surgery, what do you think we're going to do to that child or adult when they come into the emergency room? As far as diet's concerned, right? So when they come to us, we're going, and they come in, and if we suspect appendicitis, we're NPOing the patient. We're not going to give them any food. We're not going to give them any fluids. And of course, we're going to have an IV hooked up to them. The other thing I need to find out, so that you know, because I don't always put it here, but the other thing I need to know, because they're going to go in for surgery with this, right? And when they've eaten and have drank anything, that's very important for us to know. So we'll ask the parents more than likely if it's a young child, because what we're going to want to know is, have they had anything to eat or drink in the last 8 hours? And if they have, because we have to let the doctor and surgeon know that, because that's how he's going to figure out how to do his timing to do the surgery safely, if that makes sense to you. I know my appendicitis was interesting. Well, it turned into a major fiasco. But when I went in, they asked me that, and I was eating dinner when I finally decided I need to go do it, because the pain was getting worse, and I wasn't feeling good when I was eating. And of course, me and all my infinite wisdom nurses are the worst patients. I decided I didn't want to go to the hospital first because I didn't want to pay that massive copay for the hospital. So I went to the urgent care. They charged me my $40. They went in there and checked me out. Says, "You got appendicitis. You got to go to the hospital." I was in there about 5 minutes with the guy. I said, "Well, can I get my copay back?" He said, "Nope, we saw you." And then I had to go to the hospital. And of course, as soon as I hit the hospital, they got me in there. I was NPO immediately. And of course, the doctors came in, did their thing, and they found out when I was eating it all. And of course, they ended up waiting about 5 hours before they actually decided they would take me into surgery. And the other thing, if you remember, we don't want them going to the bathroom, because especially if it's a bowel movement, because they push down, they could rupture the appendix. And of course, I was back there in the pre-op area because they're getting ready to rush me into the surgery. And I had to go to the bathroom real bad, and I had to void, is what I had to do. And a nurse came in there, and of course, I try not to let people know that I'm a nurse when I'm in getting care, you know what I mean, unless they're really screwing something up. So I was back there, and I really had to go, and I'm going to get off the gurney, and the nurse is like, "Oh, no, don't worry about it." I had to let her know. I said, "I know what you're concerned about," and I let her know that I was a nurse. I said, "But I have to void." And so she looked, and she said, "Okay," and she let me get up off the gurney. And she walked me to the bathroom so I could void. And she was a good nurse, because what she did is, when I was in there, I was standing up to void. She left the door open, so I'm sure my backside was flapping in the wind when I was in there. But I didn't care, because I had to go so bad. It felt so good to do it because all the IV fluids were going in me. But she had the bathroom door open, and she was watching me to make sure that I didn't try and sit down or anything to have a bowel movement. And if you think about that, also go hands in hands with the mother when she's at the point or when she's getting ready to deliver. We don't ever let them go to the bathroom because a lot of times they feel like they have to have a bowel movement. They sit on the toilet, they push down and stuff. And when I worked on the advanced life support, I got called out a few times because Mama ended up going to the bathroom, which went to the bathroom, and she didn't have to have a bowel movement. The baby came out and went into the toilet. And then, of course, we get called and we go there, and then we have to, play with the kid and everything else and rush them to the hospital, mom and baby to the hospital. So, that's, stuff like that we do. So just things to think about. So anyhow, we want to monitor vital signs. And of course, think about it, that's not something that should have to be talked about, because all our patients, we monitor vital signs. And of course, standard of care is every 4 hours. But remember, if somebody is in distress, we may need to take vital signs a lot more frequently, depending upon the amount of distress and change of conditions. If somebody has a change of condition, remember, we need to do vital signs if they have a change of condition, right? maintain NPO status. So we don't want them taking anything by mouth because basically they're going to go in for surgery. So maintain bed rest until surgery, basically allow child to assume a position of comfort. And a lot of times that position of comfort, they're going to curl up into a fetal position. They're going to pull their knees up and they're going to hunch over a little bit. And if you think about it, that naturally pulls the pressure off the abdomen, so they will have more comfort. And of course, if you think back to term 2, when they were talking about when they have pancreatitis, right, that's the position that we would allow the patient to be in. We put them into a Fowler's position with the knees bent, or they can lay on their side in a fetal style position because that pulls the pressure off the abdomen and provides comfort. Avoid applying heat to the abdomen. And if you think about why would I avoid heat to the abdomen? Anybody got an idea?
It can cause the appendix to rupture.
Yeah, well, how would it cause the appendix to rupture?
Dilates, doesn't constrict.
Well, you think about it, right? Why does bacteria and viruses love our body? It's dark, it's warm, and it's moist, right? So if you think about it, bacteria multiplies in heat. The hotter it is, the faster the bacteria is going to multiply. So if I put heat over the appendix, then what that will do is all that bacteria in there that's growing, that's going to cause the appendix to rupture, it's going to go into hyperdrive. So yeah, it will rupture the appendix, but the way it's going to rupture the appendix is because the bacteria is going to start multiplying because we have provided this really nice environment for it to multiply in. So that's why we don't want to put heat there, because heat will cause the bacteria to multiply. If we were going to put something on that area in the appendix, we would use cold. We wouldn't use heat. Does that make sense? Okay. So anyhow, monitor bowel sounds. So palpation should be very gentle. After surgery, monitor oxygen status, vital signs, and level of consciousness. So if you think about it, this is what we do for all people post-op, right? And administer oxygen as needed. For ruptured appendix, monitor and provide incision care as ordered. Unruptured, excuse me. Monitor abdomen for distension. So basically monitor for passage of flatulence and stools. So basically, how would you monitor the abdomen for distension? Because the NCLEX was asking, what would you do to determine the amount of distension? How are you going to do that? You get one of the paper tapes, right? And you put it on the belly button, and then you'll run the tape all the way around to the other side, and you'll measure to see what the diameter is of the abdomen. And then we would record it, and that would be our baseline when we first do it. And of course, we'll keep doing that. And if the measurements keep increasing, that will tell us how much distension they have. If they're decreasing, that lets us know that the distension is going down. So we'll measure it, right? Because we got to turn it into something objectively that every other person that comes in there will be able to do the same thing to try to make the determination, do they have the distension? Is it getting worse or is it getting better? If you think about it, we always monitor for the passage of flatulence and stool. So if you think about it, what will the passage of flatulence and stool tell us? Now remember, this is after surgery. So if you think, right, everybody knows to check bowel sounds, but the other way to let me know that peristalsis has returned is the patient will start having flatulence, right, passing gas, basically farting, if you want to put it into lay terms, right? But they'll start passing gas, and you can't pass gas unless you have peristalsis. And same thing, you can't pass stool unless there's peristalsis happening. So we're going to watch for that to make sure that we got peristalsis along with monitoring bowel sounds. So they just didn't put monitor bowel sounds, they said monitor for the passage of flatulence and stools, which would be an indicator that our bowel sounds have returned after surgery, because when they have the surgery, they're going to be under general anesthetic. So basically everything's going to go to sleep. So we need to make sure that it wakes back up before we start introducing anything into the GI tract. So, you know, if you remember, we always check the gag reflex before we introduce, right? And if they've had general anesthetics and stuff like that, where the colon has gone to sleep, we don't want to introduce anything until peristalsis resumes. Because if we do, then what will happen is whatever they just going to sit in that part of the intestines, and that could cause a blockage. So once the patient's passing gas, or they, you know, basically that tells me, along with bowel sounds, that yes, peristalsis has returned. It's now safe. The doctor's ordered for us to start giving them fluids and stuff orally. Administer analgesics as needed. Encourage early ambulation. Remember, early ambulation is basically what they always do nowadays, because early ambulation is the best way to prevent a lot of different complications, right? You know, our turn, cough, and deep breathe we're going to be using incentive spirometers. We're going to be doing leg exercises, you know, to prevent DVT and stuff of that nature. But the best way to prevent these stuff, you know, from preventing pneumonias and DVTs and atrophy of the muscles and everything else is to get them up and ambulating as soon as possible. So, you know, we're going to try and get them up as soon as we can, get them moving around and doing that. Provide a small pillow or stuffed animal for abdominal discomfort. So if you think about it, this will allow them to be able to brace the area to make it feel better. We're going to teach them to brace it, you know, when they're coughing and everything else, so that, you know, they don't have the discomfort when they're coughing and stuff and doing the other stuff that they need to do. Reinforce teaching about incision care and monitor for signs of infection. And so, you know, so if you think about it, you're an adult, right? Immediately post-op, we're considered about ABCs, right? Airway, breathing, circulation. So, you know, are they able to move air in and out? Are they breathing appropriately? And circulation is bleeding. So we check and make sure they're not bleeding or anything else after the surgery, and also our fifth vital sign, pain. So immediately after surgery, those are my priorities, right? Because, and I just say that because here it says monitor for signs of infection. When would I start to see signs of infection if it develops? Will I see it immediately after surgery? Everybody's thinking out there. Okay, if you think about it, right, my infection, it'll take around 3 days before the signs of infection would start to show. So if they're 24 hours post-op, you know, my ABCs and pain are what my priorities are, right? Now, if I'm 72 hours out, you know, 48, 72 hours out, now infection becomes a major one, because bleeding is not going to be that high of a risk factor at that time frame, because the incision site should be closing up. Does that make sense to you guys?
Mm-hmm.
And so when you get those types of questions, you sort of have to think and look. If there's timing in a question, that timing is there for a very specific reason. And so you have to think about, okay, it's, you know, 72 hours post-op. Let me think about that. What is going to be my major things that I'm going to start looking for? Yeah, my ABCs and pain come in, but infection can start to develop there. So infection is going to be a high priority, along with, you know, it could be pain. But at that point in time, you know, their pain level should have started to diminish from the surgery. So it should be diminishing. If it stays consistent, then there's another issue happening. So hopefully that makes sense a little bit. It's all about thinking about how this stuff is going when you're doing these questions. Just like now on the NCLEX, do everything generic. You know, the medications are all going to be generic. And when they're talking about patient, they'll just say a patient. But if they say a female patient or a male patient in there, more than likely they are talking about something very specific to a female or something very specific to a male, and you're going to have to figure that one out. Sort of like, get my brain, I'm getting older, my brain doesn't work so well. What's the name of that medication? Accutane, right? It's the retinoid, right? You remember that from term 2 and all, used to treat acne and all that, right? If you watch, you're supposed to stay out of the sun because it's photophobic, so you can burn really, really easy, right? You're not supposed to take any vitamin A supplements. And if you're female, you're not supposed to get pregnant, right? So if you were there, they could have all 3 of those options in your answers. It says a female patient is taking it. Well, you have to realize, you think, well, all 3 of these answers are correct. No, they're not, because it said female. So I know that basically my female, she's not supposed to get pregnant, or my female has to be using a reliable form of birth control while on that medication. That would be the appropriate answer. The using sunscreen and wearing long sleeve shirts, pants, because it's photophobic, that doesn't come into play. Not taking extra vitamin A wouldn't come into play because they're asking specifically about a female to see if you understood, if it's a female client, what's the most important thing to make sure of. She don't get pregnant, so we need to make sure she's using a reliable form of birth control while she's taking that medication. Does that make sense to you guys?
Mm-hmm.
Hopefully. I just try and throw some stuff out that they can come along. So there's just another picture of the appendicitis coming up. So basically, like it says there, I'm not going to do it, the peak, normally 10 to 12, but, you can be in your 50s or 60s. Appendicitis can happen at any time, but, most of the times, the highest incidence is between 10 and 12 years old. So, they're in the school age bracket, basically, for the most part, when it most likely will start to hit them. So anyhow, therapeutic procedures for ruptured appendix. So basically, we got IV fluids, antibiotics, basically electrolytes, NG to suction. So they're basically, the patient's going to continue to be NPO. They're going to put an NG tube down, hooked up to suction. You have surgery. Basically, wound may be left open or closed. A lot of times, if it's ruptured and they know that it was ruptured, once they go in there, they're going to flush out the abdominal cavity with antibiotic type of solution to try and get all that bacteria and stuff out of it. They may close them up, or they may leave it open because they may need to be doing antibiotic when they do the wound cleaning. They will use an antibiotic solution when they're doing it, and of course analgesics. Basically interventions. So basically, it's going to be pretty much the same for an unruptured, just with a few differences. So basically, after surgery, provide wound care and irrigate as ordered. Note the quantity and characteristics of drainage, so they will have drain tubes in. Maintain NG tube to low intermittent suction. Administer analgesics on a routine schedule. Meaning, if the doctor prescribes it every 6 hours, then we're going to give them the analgesics every 6 hours for the first few days after surgery. And also remember, if they ask you how to put an NG tube in, if I have an NG tube going to suction, how am I going to put the NG tube into the patient? So then I had a student tell me they had that when they did their NCLEX and stuff like that, and they came back, they're all concerned. So if I have an NG tube going to suction, how do I figure out how to put it into the patient?
I don't know that.
So keep in mind, we're talking about NG tube, right? So how do we do an NG tube? Tip of the nose, tip of the ear to the xiphoid process. That's how we're going to measure it out, because even the ones being hooked up to suction, we put it into the stomach, and then from the stomach, it's going to work its way into the small intestines and go to where it is. The difference is that, when they have an NG tube suction, you can tell a lot of times because one has a weighted tip on it, and they might have 4, 5, 6 feet of tubing on it that will be curled up by the patient to allow the NG tube to work through the GI tract to get to where it needs to go. And typically when they do that, what's going to happen is they'll take periodic x-rays of the patient, see actually where the NG tube is, and then once it gets to that area, then they will tape it to the nose and hold it in that place, just so that you're aware of that, in case you get any type of questions along the lines of that. So basically ambulate in the room, sit in a chair at least 3 times per day. Due to emergent nature of surgery, encourage child and parents to express feelings and ask questions. Never administer laxatives or enemas to anyone exhibiting severe abdominal pain. So anybody has severe pain, we don't administer laxatives or enemas. That's going to be up to the doctor to look at, because it could be they have a blockage or something else happening in there. And also, like says, these can increase the risk of perforation. Necrotizing enterocolitis, so this is talking about the large intestines, acute inflammatory disease related to ischemia of the bowels, immature GI defense, and bacterial proliferation causes devastating damage to the bowel walls, which results in tissue death. So basically, the colon is dying. So normally onset is 4 to 10 days after feeding are initiated. So this is just sort of a picture going all the way around with what it is. So basically contributing factors, basically risk factors, prematurity, neonate who has complications, basically respiratory distress, birth asphyxia, shock, polycythemia and infections, uterine growth restrictions, of course, neonate who has received an exchange and or enteral feedings. So some unexpected findings. So they got a lot. They can have abdominal distension. So remember, we would measure the abdominal girth, basically lethargy. So they're real like tired, fatigue, no energy, high gastric residual, apnea. So remember, apnea is periods of not breathing. So apneas that worsen, hypotension, anemia, metabolic acidosis, leukopenia or leukocytosis. So the white cells can go either way. Leukopenia would be the white cells would be low. Leukocytosis, white cells are elevated. So it can go either way with that. Electrolyte imbalance, bloody stools, sausage-shaped dilation of the intestines, bowel-stained emesis, and all that good stuff. You can read the last couple, there's a bunch. So laboratory tests along the lines goes there. Of course, you're going to take the x-rays and all, just take a look at what's happening, run a CBC, arterial blood gases, because it can have acidosis, blood cultures, and of course electrolyte panels to see what's going on with the electrolytes. So basically prevent it by withholding feedings. Prevent by withholding feedings for 24 to 48 hours for any neonate who has experienced complications. So minimize enteral feeding and encourage breastfeeding. So like it says with them, we withhold feedings for 24 to 48 hours, and basically if they've had complications. NPO, NG to low intermittent suction, IV fluids. So basically here, correction of the hypovolemia and electrolytes. So basically oxygen, serial abdominal x-rays every 4 to 6 hours, surgical intervention to remove necrotized bowel. So they're going to have to go in and remove the dead bowel tissue out of there. And of course, we'll put in a temporary colostomy, basically. Monitor bowel sounds, gastric residual and stools. Monitor vital signs, which we do for everyone. And of course, blood pressure and oxygen sats are part of our vitals, right? Monitor arterial blood gases. Avoid measuring temperature rectally. And like I said, most of the times now in children, we don't measure rectally anymore. We'll use oxillary, or we might do the temporal or tympanic. Leave client undiapered to prevent pressure on the abdomen. Position supine or on the side. Measure abdominal girth. Institute strict hand washing. isolate infants who have confirmed cases. So if they have necrotizing enterocolitis, they have to be in isolation, maintain clients with oxygen, and provide respiratory support as needed. Monitor for septicemia, disseminated intravascular coagulation, DIC, and hypoglycemia. Surgeries there provide routine postoperative care, including analgesics, perform colonoscopy care if indicated, provide emotional support to parents, encourage them to share feelings and ask questions. So reinforce teaching about protective quality of breast milk. And basically what that is remember the first milk that comes out, that's the mother's antibodies the child is getting. That's why we normally promote, and even if somebody says they want to bottle feed, we're going to try and talk to them highly about breastfeeding for at least 3 days after delivery. So they get the colostrum, basically they get the antibiotics and everything, so they get passive immunity from the mother. Basically. So prepare parents for surgical intervention as needed for possible long-term complications. So, and of course, it's got some of the complications listed there. We did get through it. I was wondering if I was going to get through. And I will do this here real quick. Okay, I posted my email in there because if you want to copy the slides, all you need to do is just send me an email and then I will attach the slides to you because I don't have your emails or anything like that, so I'm not able to do it that way. So just make sure you do it. Like I said, the sessions at night, I'll cut it here in just a second, but the sessions normally, like I said, are from 6 to 8 o'clock. Some of my sessions, they run almost all the way up. And some of my ones I may get done early. It just depends upon, how much information I have to try and get through. So it can sort of vary, but I always stop at 8 o'clock because that's when we say we're going to get finished. And I don't want to hold you guys over because I know you probably have other things to do or studying or whatever. So hopefully this is beneficial a little bit to you tonight. And of course, I'll be back on tomorrow night at 6 o'clock. I think I'm covering the next section in this here, working the way through it with it. So other than that, I'm done for tonight. So
when's the next time you'll be back?
I'll be doing it tomorrow. It's my days for this is Thursday, Friday, 6 to 8 o'clock.
Okay.
As far as getting PowerPoints, goes all in one message. For me getting the PowerPoints ahead of time, I don't have any of the stuff to be able to actually send it out ahead of time. If you send me an email, I guess tonight or whatever, because I'll probably be looking at the emails tomorrow during the day, so I can send out the slides if you guys want these slides, and if you tell me you want me to have the ones for tomorrow night, I'll see if I can try and attach them as well to send it to you. It's a little bit time consuming with the way I have to do this because I have to have you send it to me individually, and then I have to individually one by one send PowerPoints out. So, but I'll try. So yeah, you guys have.
Thank you. You have a good night.
Yeah, you guys have a good night. We're done. So
what are we going?
I'll see y'all tomorrow night.
What are we going over tomorrow?
I gotta look at my thing here for a minute. I gotta look at my calendar. Let me see if I got it here. Yeah. So tomorrow it's going to be acute conditions of the children part 2. So it's the second part to this one. I do it because a lot of times everybody always freaks out, but you'll find out when they have other conditions like adults, you find out it's pretty much the same thing. There's just slight differences with the children, but it's the same. So I'm covering this for right now, and then the next week I'll be getting into hematologic disorders, cardiovascular systems, and moving through like that. Okay?
Okay.
All right, so and just make sure your name's in the chat box for me, and basically I'll see you guys tomorrow night. Have a good night.
Whew.